Thank you, sir, and thank you, judges. At the outset, none of the authors have any financial disclosures pertaining to this study. So we are going to navigate you through the worldwide impact of dry eye disease, the background and need of personalized intervention, the purpose of the study, and why do we need TIA biomarkers, the methods on how to analyze these biomarkers, and how we can use these biomarkers for customized treatment strategies. So if you see on the left side of your screen, you can see how a healthy ocular cell would look like. But whenever they are under any stress, be it desiccation stress or inflammatory cells, they start losing the normal morphology and functions of the cell, and they start secreting excessive inflammatory biomarkers. And when we treat these two kind of patients, the set 1 patients are going to respond very well to our conventional and the first line of therapy, but the second set of patients are going to stay dissatisfied. They will try different treatment options, and they may seek opinions from a colleague, and at times they are still dissatisfied. So a non-responder in dry eye is the one who experiences persistent symptoms with objective measures like tear film stability or corneal health not improving as expected despite giving the recommended treatment plan. So the global incidence of dry eye is increasing, affecting almost 350 million people per year, of which 60% of the patients report having a poor quality of life in terms of their daily routine activities. And this does not affect the financial burden to the family, but to the global community as well. So we are at a stage that it's extremely crucial for us to identify the cause of this non-responder patients with advanced diagnostic tools and consider the customized therapy. So our question was, can we identify the root cause of why some patients respond to the treatment and not, and can we customize the treatment for these patients with the aim of providing them with tailored treatments? So our group has developed this BioM Pathfinder kit with which we can measure 8 biomarkers, both inflammatory and non-inflammatory, and this is an ELISA-based technology which uses the microfluidic system, which will give reliable and repeatable results. So you can use tear fluid or any ocular fluid. Tears can be collected using Schirmer strip. At the end of 5 minutes, you take it in an Eppendorf tube, add a patented buffer solution which comes to it, and shake the tube for 5 minutes. At the end of 5 minutes, you take the 50 microliters of buffered solution and introduce it into this well and put it into this analyzer system. At the end of 90 minutes, you're going to get this detailed report for each of these 8 biomarkers for each of the eye, whether they are normal or abnormal based on the reference interval. And you can choose the treatment for the same. So this study included 5,270 patients who visited our dry eye clinic. Based on TFOS due to classification, they were started on treatment. At 3 and 6 months, we did a dry eye matrix and a comprehensive dry eye questionnaire to find out the non-responders. And the non-responders were further subjected to tear biomarker testing using the BioM Pathfinder kit, and the abnormal biomarkers were treated with personalized biomarker-based therapy. 64% of the patients were non-responders to the first line of management in a tertiary eye care hospital, in which 27% patients had high MMP9, 17% patients had high ICAM1, and 20% patients had a combination of high inflammatory biomarkers. Based on 1-fold, 2-fold, or 3-fold rise, they were treated on trehalose-based drops or a combination of trehalose and cyclosporin. And if this was a 3-fold rise, we added a vector pulsation therapy. And at the end of 6 months, the non-responders came down to 2.3%. Group which had high ICAM1s, it was 17%. They were treated with a combination of lifitegrast and trehalose. And at the end of 6 months, the non-responders rate came down to 0.7%. The group which had high IL-17 were treated with 1 sitting of vector pulsation therapy or 3 sittings of IPL, and the non-responders rate came down by 11.2%. And the group which had a multi-markers, inflammatory biomarkers which are on the higher side, 3 sittings of IPL therapy plus trehalose plus cyclosporin and doxycycline was incorporated. And post-treatment of 6 months, the non-responders rate came down by 0.6%. So cumulative non-responders rate from 64% came down to 4.4% with this targeted biomarker-based therapy. So incorporating a BioM Pathfinder kit into clinical practice will not only provide you with an immediate report, but also reduce the cost for the patients. And evaluation of 8 biomarkers might cost only 1,500 rupees. And moreover, this test can be conducted by a technician, and it is as small as a projector which can be kept in your clinic. So this is the biomarker kit which may help us discover and stratify abnormal levels of inflammation and have a targeted therapy for the same. And a more economical management can be provided by avoidance of multi-drug therapy in previous patients and avoid treatment failures. This CAT kit can be used for keratoconus, post-op unhappy cataract and refractive surgery patients, diabetic patients, and many more. And this is now available for use in clinics.
Thank you. My team for helping me present this work on
Very
their
nice
behalf.
presentation,
Thank
Dr. Pooja. You have already mentioned that MMP9, ICAM, and the IL are the main biomarkers. Any new biomarker that you could find in your study?
So ma'am, what we have done with the kit, because it's going to be a clinically deployable kit, we have chosen the biomarkers which are common across dry eye and multiple other diseases like retinopathy, ARMDs, and vascular occlusions. So we have begun with those common biomarkers, and it has IL-17, IL-1 beta, IL-6, and VEGF. And it has IL-10, which is an anti-inflammatory marker. So it's a combination of 8 biomarkers. At this point of time, it's just 8, but as we move on, we will have more and more biomarkers incorporated in this kit.
So will this also help you differentiate onto the specific therapy that you want?
Yes, sir. So it will help. Yes, sir. So it will help us to, for example, a patient walks into my clinic. He's gone to 3 doctors and come to my clinic. He's not unhappy. So I can do the test, find out which of the biomarker is abnormal.
Non-responders, supposing
Yes.
a fresh patient.
Fresh patient also, sir, we can do the same.
You can do this, but how will it help you decide whether you want to go in for cyclosporin or you do not, or you want to go in for tacrolimus or you want to go in for other? How does it help you differentiate as to what therapy to be? I'm talking of a fresh patient coming to you.
So-
You're talking of a non-responder that I know that I have given cyclosporin, he is not responding to cyclosporin. So that's my only question.
So for a non-responder also, based on which biomarker is higher, we can give a similar treatment. For MMP9, the low dose, like if the MMP9 level is on the lower side, which is abnormal but on the lower side, a 3 halos drop. If it's a two-fold rise, let's say the normal range is 49,000, but my patient has 1 lakh, I will add a cyclosporin plus a 3 halos for that patient. And if that patient has, let's say, 1,50,000 or 2 lakh, then I would add a vector pulsation therapy or an IPL therapy, which is available in my clinic, and that's why I stratify the patient. But if my patients don't have MMP9 higher, but my patients have IL-1 beta or IL-6 higher, then I know that cyclosporin or a 3 halos may not work as a primary line of management. And that patient, even if I give a lubricant drop, tomorrow that patient is going to need a modern day dry eye therapy like an IPL or any vector pulsation therapy. So
Very
that's how I
nice.
can stratify in the primary place as well.
Thank you.
Thank you, sir.